Welcome to Dr. Lottie's Science with Soul, the podcast that transcends the boundaries between science and spirituality. Prepare to be uplifted, transformed, and awakened to create a path to healing your own life physically, emotionally, and spiritually by bridging the gap between science and soul. Welcome back to Dr. Lottie's Science with Soul. Today's guest is Nancy Petersen, RN, who is one of the most recognized endometriosis advocates of our time, having spent decades engaged in personal and professional efforts to connect women to better care. She's also a woman who has experienced endometriosis herself. Nancy has accomplished many major milestones throughout her career, not only on behalf of her own medical patients and by universally expanding the role of nurses, but for women and girls with endometriosis globally through advocacy of complete removal of endometriosis. Nancy continues to tirelessly educate lay, media, and professional audiences on the modern concept of endometriosis and has helped improve the quality of life for countless of women all over the world through her outreach and education efforts, as well as establishing Nancy's Nook, a Facebook resource group for disease education, discussion, and support. Welcome back to Dr. Lottie's Science with Soul. Today, I am so excited because I have a very, very special guest, Nancy Petersen. And I cannot wait for her to share her knowledge about endometriosis with you all because it's something that consistently falls through the cracks. And I see a lot of people myself that fall through the cracks and have seen many different surgeons, have seen many different doctors, and it consistently is mistreated. So I am going to introduce you to Nancy Petersen and let her share all her knowledge with all of you guys today. So welcome, Nancy.
Thank you very much. I'm very happy to be here and always happy to have an opportunity to share what we're learning about the disease and the patient's journeys.
So Nancy is one of the most highly regarded names when it comes to endometriosis. How did you become so knowledgeable about this disease and also an advocate for endometriosis?
Well, there's a story. First of all, my first painful period was age 10, and I ruptured cysts for about 10 years, actually 17 years before I got a diagnosis. And at that time, it was to try birth control. If that didn't work, well, we'll just have to take everything out to cure you. And so the birth control didn't take. And so I took everything out for the cure. And when that didn't work, they suggested that I have a laminectomy infusion to deal with the back and leg pain. And when that didn't work, they sent me to a psychiatrist. And so I spent 22 years dragging around a white, hot, blisteringly painful left leg. Was getting slowly smaller. There was muscle wasting going on. And I continued to work, but it was extremely difficult. I moved to Bend, Oregon in about 1974, and I moved through different jobs there and went to work as evening supervisor about 1980. And one evening when I was making rounds, I got a call from the operating room, said, "We need food. We've been on a case for hours. We didn't get to dinner. We're not going to get free." So supervisors did all kinds of things in those days. So I trucked to the kitchen, got a tray, sent it. I was having so much pain, I grabbed a cup of coffee and I sat down in the cafeteria for a minute. And in the back of the cafeteria was this new young gynecologist who was talking to a group of patients who were interested in endometriosis on some local research that he had done. I only got to hear part of the lecture before I got called away. About a year later, I bumped into him and I said, "So, how's your research doing?" He said, "Oh, it just got accepted for publication. I'm really pumped." And it had been accepted in 3 mainstream journals. And so I asked him, I was co-chair of the hospital's research and development committee at the time. I asked him if he would present that research to that committee. And he said, "Well, what are you going to do with it?" And I said, "I don't know. I think we need to know what you're doing." And so he did, and they were kind of impressed with it too. And so then I took him to the administrative group and he presented there. And when he left the room, the administrator said, "What do you want me to do with that?" And I said, "I want you to give me some money. There are support groups all over the US and Canada, and women are in trouble, and I think we can help them." And so reluctantly, they decided they would do that. And about the same time, I contacted a little magazine in Northern California run by a physician who was always looking for things that was a little bit different, but that worked. And it was called Medical Self-Care at the time, only had a small circulation, about 60,000. But he was really interested. And so he sent a writer and a photographer up, and the writer and I co-wrote an article called Endometriosis Reconsidered. And the week it was published, we had 1,000 phone calls.
Oh,
And
wow.
so the hospital switchboard in this little rural town is suddenly swamped. Everybody's saying, "What have you done?" That was the start. And I spent 10 years then on the road lecturing, interpreting his findings, which are very different from the old history, the old myth of the disease, to groups of patients and nurse practitioners around the US and Canada. I spent about 25 weeks a year on the road for about 10 years. And so suddenly what was happening, the crowds were very large. I mean, people were so anxious for information. In Canada, they would travel 2 days to hear me lecture. And I was just so honored that they were willing to hear what I had to say about his research. And that kind of was the groundwork for how I got involved in this. But in Saskatoon one night, I gave a lecture on endometriosis. And after it was over, about a dozen people kind of hung around afterwards. And the rest of the crowd kind of filtered out. And I said, "Well, if you'd like to talk, why don't you just sit down and tell me about your histories?" And the whole time I'm listening to this, I'm going, "Geez, it sounds like me." I'm still dragging around a white hot leg, right? So I get home, I'm supposed to have my gallbladder out the next week. So I said to Dr. Redwine, "Say, would you mind stopping by the OR and taking a look?" He said, "No, it doesn't work like that. You have to come to the office for a consult." So he did, and he managed to get into the OR the next week. It took him almost 3 hours to remove the rest of my endometriosis. I woke up in a recovery room pain-free. I no longer had a cramped calf or a hot leg or a numb foot. And frankly, it made me mad. Nobody should have to live like that. By then, I was 49 years old. I had lived with endometriosis pain since I was 10. And that's how I got into it. It just, nobody should have to live like that. Many of the cases I work with now are every bit as bad or much worse than mine. And no one should have to live like that. So many are still being gaslit. In Nancy's Nook, we take in between 2,500 and 3,000 new patients a month. We'll hit 200,000, I think probably in another 6 weeks or so.
Wow.
The Endometriosis Research Center had asked us to start a small discussion board about 2008 or 9, something like that, on Yahoo, and it didn't work out very good there. So they suggested we open Facebook. And they suggested we call it Nancy's Nook, and we took 200 patients to Facebook. And I think it was about 2010.
Wow.
And we'll get 200,000 shortly.
Wow.
Did that answer your question?
Yeah, I mean, that has grown a lot. And so for people who are listening, they are thinking, "Oh, endometriosis, isn't that in the uterus? Why did you have leg pain and back pain?"
Well, there's lots of problems with that. It's always been thought of as a disease of fertile women, basically. But really, the youngest patients we've seen have been in, John DeLumba in Texas has a documented case at 8 years old, not yet menstruating. Many of our patients are post-menopausal. Redwine did a series of cases in their 70s, and that we've seen a number in their 80s. So it's a disease across the spectrum of age of women and transgender. And so we've always thought of it uterus, tubes, and ovaries, but Redwine's work in the 80s showed us that those aren't the most common sites of occurrence. In fact, when you document it, and we send patients, when patients come to us, they've had a diagnostic laparoscopy and they're told that They have a pristine uterus, tubes, and ovaries. They don't have endometriosis, but they have classic symptoms. And so we asked them about their diagnostic laparoscopy. And what they tell us is it was a single scope. It lasted 15 minutes. Everything looked fine. Well, we've had some wonderful experts around the world help us with that. Professor Mohammed Mabrouk from Cambridge in London, and Megan Wason from Phoenix, and Cindy Mossbrecher from Washington State, who, by the way, is the only physician that Redwine trained, and she was with him for about 2 years. But all of them have helped us understand that a simple laparoscopy doesn't move the uterus, tubes, and ovaries out of the way to expose the most common sites of occurrence. So there's this long history of believing it's a disease of reproductive age women. It's on the reproductive organs, and if they'll just have a baby, or they aren't having enough sex, or whatever, all this myth grew up around that. And so it's been hard to fight that. We find it in the diaphragm, we find it on the small bowel, the large bowel, the pelvic floor, the ureters. A couple of years ago, we did a survey in Nook and found in just a matter of an hour or so, 18 patients had lost their kidneys from obstructed ureters. So we really have to broaden our understanding of what the disease can do. And I think we're seeing a number of what I call, groups of excellence in care, really developing all around the world. It's just not enough. There's about 200 million patients worldwide, and I don't know how many surgeons, maybe 1,000, maybe 2,000 surgeons who can really handle that disease. So I think that's part of the problem, is what we learned about it originally was not accurate. So.
Yeah. And so you talked about how even young children can have endometriosis, and even there was a case with an 8-year-old who wasn't even menstruating yet. So for people who are listening, what kind of symptoms would a young girl have when they're not even menstruating yet?
What we've heard from Dr. Dilemma and a few others who've seen really young kids is abdominal pain, irritable bowel. And very often, first they'll think about their appendix. They don't find anything to support that. The kids aren't eating well. They're constipated, or they're having diarrhea. They're having lots of abdominal pain, sometimes some bloating. Although we probably don't see as much bloating prior to menstruating, but they're in pain, and they generally have a misdiagnosis of it, something related to diet or allergies or whatever. So we've not seen,
anxiety, right? I think they all, with stomach pain and a young child, there must be anxiety about school. I've heard that one.
Yeah, that happens a lot. And of course, even in adults today, when we had our program in Bend, it was active from about 1985 to almost 2000, I think. 75% of our patients have been dismissed as neurotic. But we kind of had an edge on that, because everybody who came to Bend had a surgery. And so we had positive biopsies on all of those patients. Nobody had negative surgeries. And so I've always been a little concerned about that anxiety type diagnosis. And we're seeing, even today, a lot of mental health diagnosis and dismissal because of mental health, and the other thing around central sensitization. To me, they're using those tools in patients who actually have endometriosis. Two groups have sort of raised questions about that, but it hasn't been well looked at. Dame Shirley Pierce, who was a psychologist from the United Kingdom, about 30 years ago, wrote a chapter in a book called Psychology and Gynecological Problems. She wrote the chapter on chronic pelvic pain. And what she found was that patients with chronic pelvic pain had abnormal MMPIs, or personality index testing. So they had things like psychosis, neurosis, schizophrenia, anxiety, all of that. She was the only person that went back and looked at those patients when they were pain-free. All of that went away. So I think it's a coping mechanism. And I think the same thing is happening with central sensitization. A group in China here, about 2017, I think, looked at their patients after they got their endometriosis excised and their pelvic pain was gone, the central sensitization began to clear up.
Yeah. So what happened to the central sensitization when after surgery?
Yeah, it starts to go away.
Yeah. And so central sensitization, for people who are not familiar with that, can you just briefly touch upon that?
Well, I'm not well versed in it because I abhor it so much because I know that patients get better, but it's the concept that the brain picks up on the presence of pain in the body, and that it's hard for the brain to let go of the fact you've been in pain in the past. But most of our patients who have that diagnosis still have active endometriosis. So I'm always a little cautious about having them accept that diagnosis.
Mm-hmm. Yeah. So even when they have surgery, uh, what if there is lesions left behind? Let's say somebody had a hysterectomy, a complete hysterectomy. So they took the ovaries, they took the uterus, there's nothing left. And now they still have some lesions left behind. What happens with the hormone production there?
Well, when you take, there's been a common misconception: if you just castrate a woman, her disease will go away. Cedar Bulin, I think maybe about 20 years ago, was a researcher in the Chicago area, noted that the endometriosis lesions themselves produce estrogen. Others have said they may produce other hormones as well. So you can take all estrogen supplies out of the patient's body and the patient will still have pain. I was 22 years post hysterectomy on no estrogen replacement and had agonizing pain. And many of our patients experience that. So we have that misconception: if you just take the ovaries or you shut down their ovaries with medication, anything, put them into either natural, surgical, or medical hormone or menopause, their disease will go away or quiet down. And that's not what patients are experiencing.
So what happens with patients that have endometriosis and they go to the doctor and they say, well, we're just going to give you some, birth control pill. And, the things that you hear is, you shouldn't have surgery yet. Just wait and have surgery until you want to have kids. And meanwhile, the patient is dying in pain. They can't function. They can't go to work. They're in extreme pain. And then they're given birth control pills. And then they react to the birth control pill. Um, what do you think about that method of treatment?
I think there's perhaps some acceptable level of trying a patient on birth control pills if they come in with painful periods. They may have just painful periods and you may be able to help them. But in fact, you can't treat endometriosis with that. Even if you reduce their pain, you don't stop progression of the disease. And the concept of let's just wait till you're ready to have kids allows the disease to progress. And so pretty soon you've got adhesions. You develop adhesions from surgery, yes, but you develop adhesions from inflammation. Endometriosis causes a lot of inflammation. And so these patients are now thinking, well, gee, I've got to wait till I'm ready to have a family. I've got to put up with all this pain. But in fact, their disease can progress. I don't want to give the misconception that all disease progresses, because I don't believe it does, but a lot of it does. And I always say to people, when a doctor say, well, why are you telling patients to get their disease out early? And I said, well, DIE, or deeply invasive endometriosis, didn't happen overnight. I mean, it's been there a while. And why let it get that bad? I have, I've noticed a pressure in recent years. We don't have to operate on everybody. I mean, we can find ways to control their pain. We don't eradicate their disease with medication. We don't stop progression. We don't completely control their pain. To me, it's misogynist rationing. We really don't want to spend the money to take care of these patients worldwide. Mm-hmm. And it's becoming increasingly frustrating for me, because I've even seen some good surgeons say, well, I didn't take everything out, because you can clean the rest of that up with diet and exercise. There's no evidence to support that at all. So where's that coming from? Is that restlessness? I don't have enough time to do that. I mean, I know that the work we've done, not just my advocacy group, but the advocacy groups around the world, have put a lot of pressure on physicians, because patients want freedom from pain. And so I know we're pushing them hard, but there are programs beginning to respond to train more surgeons, at least to handle the less complex surgical disease. But the concept of leaving disease until it's so bad you can't manage it, or until you're ready to have a baby, I think is not the right direction.
Mm-hmm. Now, you mentioned the inflammation that happens. There's a lot of inflammation when the endometriosis is left behind or not treated correctly or excised out of the body. So, when somebody has all that inflammation going on, what happens to all the comorbidities that go along? Are these patients now more likely to develop other diseases such as lupus or multiple sclerosis or rheumatoid arthritis or other inflammatory conditions?
It's extremely good questions. The problem is we don't put any money into research for this to answer those questions. If you look at it anecdotally, we see that a lot of our patients, our patients coming in to Nook looking for information have multiple inflammatory conditions. And they always ask those questions, and we don't have any good answers. I think the new move going on, perhaps with the Biden administration's Women's Health Initiative, and certainly with Shannon and Patricia Cohen's film Below the Belt, now looking at distributing that worldwide, has really raised a lot of questions about why aren't we asking the important questions about this disease. And, it's a long haul. I remember when Dr. Redwine's work was first published in the late 1980s, there was a former professor from Stanford who'd moved to Central Oregon. And he was reviewing the work, and he said, this is really good stuff. And he said, but you have to understand it's going to take 30 years for this to be accepted. What I didn't understand was it was going to take 30 more for it to transform the industry. And that's kind of where we are right now. We're seeing training groups all around the world. Every year I get notices, dozens of notices of high quality endometriosis surgery education opportunities for physicians. And I think that is critical, but it's not enough, and it's going to take time. Mm-hmm. Another thing that I think has been extremely helpful is the work that Dr. Sally Sorrell and Andrea Vidali have done in terms of the Endometriosis Summit every year. They bring together practitioners, researchers, patients, and it's kind of a free-for-all. I mean, patients get to hear the best of the best, and they go home expecting that, which is to make their local doctors happy all the time. And I don't want you to go away thinking that I'm the best in the world, because I have some detractors. I have some very aggressive detractors. And, I'm sorry about that, because I think it makes other patients maybe a little concerned about, well, maybe Nancy's Nook isn't the thing for me, or maybe there's nothing there for me to learn, but every day we get feedback from patients about their lives being restored. So we know we're on the right track, but I'm not 100% loved.
So the Endometriosis Summit, so that comes up, I believe, March 8th through 10th in 2024. Yes. So and we'll put a link to that in the podcast notes as well. And that is an excellent resource to participate in that. You can participate in person, or you can participate virtually. So anybody out there that is struggling with endometriosis and you can't travel because you can't plan when you have endometriosis, because you might end up being really, really sick and you're just going to lie in the hotel room, right? So it's very difficult for these people. So the fact that it's offered virtually is great, because it really reaches a lot of people that way. But the kids, so when you go to the doctor and the doctor says, taking my own daughter, because I have endometriosis myself, undiagnosed endometriosis, self-diagnosed now that I'm a doctor. But so my daughter had really bad endometriosis, and I remember taking her to the OBGYN when she was a teenager. Okay, this is not resolving. We've been, trying the pain medication, and now we're trying to birth control, and then we try another birth control, and then we try another birth control. And she would always have side effects to all the different birth controls. So is it common that people that have endometriosis tend to not do well with birth control?
Yeah, they don't do well. Not really, not much of it completely relieves pain. Every new drug that comes out, sort of lots of hype around it. This is great for, they used to say for treatment. Now they've backed off of that. And the new drugs that come out are really identifying we're treating pain, not endometriosis. But most of them don't give complete relief. And so it impacts sexuality, it impacts their ability to participate in their family. It impacts their ability to bond with their kids. I did a survey in Nook, and I just left it open for mothers and kids to talk about the impact of endometriosis on being on in the family. And very quickly, in just a matter of a couple hours, we had 300 responses of people saying, I can't bond with my kids. I can't get off the couch. And I've had 3 different patients now tell me about the impact, of having, they often get told to have a baby. If they can get pregnant, that's going to help. That doesn't help any more than birth control. But I've had 3 different patients now tell me that they've gone to their doctor's office and said, look, the birth control isn't helping me. I'm in agony. I'm exhausted. I've got 2 toddlers at home. I can't manage this. I'm not able to bond with the kids. I can't participate. I can't even play with them. And they've had doctors say to them, you weren't pregnant long enough. Have another baby. And we're going, oh my God, this just can't be. This just can't be. The treatments help pain. They don't really treat pain. I think probably the GnRH family of drugs are somewhat more concerned because most of our patients who've tried those have permanent side effects, and they're significant side effects. It's not just bone loss, it's bone pain, it's joint pain. These people are not doing well. And I think the FDA had about 25,000 side effect complaints filed with them, including 150 or so deaths. But you never hear anything about that in the literature. When that was discovered, Dr. Redwine was asked to do an assessment of the data that was used to move Lupron from prostatic cancer to endometriosis. When that assessment was done, it showed serious problems with the drug, but the drug company got a court order to shut that down. So doctors and patients never had a chance to have an informed consent about the use of that drug. And so it's unfortunate, but I'd never recommend that family of drugs for patients because of the risk of long-term side effects.
Yeah. So going back to the child that's 8 years old and might have stomach aches, and another clue, could it be to ask if the mother had menstrual pain?
It shows up in families for sure, and sometimes multi-generations, sometimes skips a generation, sometimes you're the only person in the family with it. You just never know. But I think there's a strong genetic component belief around it. Again, it's an area that doesn't have enough research. A lot of the research that's done is done on going back and looking at records of previous patients. We aren't currently looking at histories, and we need to do some of that kind of thing to get a better handle on what's going on.
And so now I know there are different theories, right? So we have the old Samson's theory of retrograde menstruation. But it doesn't really hold true because when you look at the statistics, 90% of women have retrograde menstruation, but only 10% have endometriosis. So it doesn't make any sense at all. And then we have Dr. David Redwine's theory of the Mullerian, so meaning that when you are a fetus in mama's womb and all that tissue gets laid down, there is a defect that's created. So, and I know that can see on ultrasound, and they have done studies where they've looked at the fetuses, and they can confirm that the endometriosis is already there. But meanwhile, when you take your daughter to the OBGYN when she's a teenager, they consistently told me that, oh no, she's too young. And, we usually can't tell if they have endometriosis until they're at least in their 30s. And we're going to try all these different things. But literally, it was there from the beginning, right?
Yeah.
So she came into the world with that endometriosis. So what is your understanding of that?
Well, Samson's theory of the reflux menstruation, there are some really big holes in that. In the first case, when you transfer a tissue from one place to another, there's initial attachment and then deeply ingraining and becoming implemented in the tissue. That's missing in endometriosis. It isn't there. And so that's kind of the first thing. The second thing is Redwine, in his research in the 80s, made arrangements with the medical examiner's office, who was doing autopsies on babies for other reasons, completely unrelated to endometriosis. He asked for samples from the floor of the pelvis, which is the most common site of occurrence, and 9% had endometriosis. There's a larger group in Italy who had been looking at abortions or aborted fetus or spontaneous miscarriages and looking at that same area and confirmed the presence of endometriosis in infants. So I think we have to be really careful about saying, it's reflux menstruation, because there's no initial attachment. There's no, deeply moving into the disease. It's very likely, I think, Redwine's concept, and I see many people supporting that now around the world, of Mulleriosis or the concept of it being laid down in fetal development. But reflux menstruation has been around forever, and it is still taught in some medical schools. And so the idea of everybody's going to have to put up with bad periods if you have reflux menstruation just doesn't hold water. But it's commonly, it's kind of like the same thing of telling patients, you just have a baby, it'll go away, or all of that. Or if we take out your ovaries, it'll all dry up and go away. Those kinds of things are just so deeply ingrained in the history that it's slow to shift.
Another thing that made me think about how all of a sudden the symptoms get better for a year, and then we were told that, oh, then it's not endometriosis. It must be something else. It's probably, an ovarian cyst or something like that. And then she ruptured her cyst, and we went to the ER, and of course they said it's a ruptured cyst, right? And so it's this constant misdiagnosis, and it just goes on and on. And I'm thinking of, how do you, as a normal person, navigate the medical treatments for endometriosis? I'm a physician, and it was still hard for me to navigate. Here you are at the ER, and they're like, okay, we got to give her morphine, and it's everything looks good. We did an ultrasound. There's nothing wrong, and then they send you on your way with no pain medication, nothing.
And no support,
out, right? And
exactly.
4 hours later, we're back in the same boat that we were earlier, right?
I've got 200,000 patients in that same boat. And I don't know the answer except education. We continue to educate patients about, first of all, those people coming out of their gynecology residencies are not well prepared to take care of endometriosis. Some of the surveys that Shannon Cohen's group did when they're doing their film, that 80% of physicians didn't know the symptoms. A lot, a very high percentage, I don't remember the exact, was that they were kind of intimidated by the disease. And all of that, I think, is a byproduct of the myth that's come up around the disease over the last 100 years. And if you don't know what it looks like, and you don't know how that changes over time, and you don't know where it's found, and you don't know the true symptom profile, and you take a patient to surgery, you just set yourself up to fail. There are basic things you have to know about the disease to be successful. And I don't think that's fully grasped yet.
Yeah.
But it's hard because, that one of the things that's happening a lot right now is the big push for ultrasound and laboratory tests to diagnose endometriosis. They're not 100%, but the whole industry out there has heard about ultrasounds are great. And so if your ultrasound's negative, you can't have disease. And what's happening is patients are being dismissed from care, just as your daughter experienced prematurely, because the ultrasound was negative, or it was probably a cyst, or it's all gone. We have to be honest with patients. We need informed consent. Yes, ultrasounds are good, but ultrasounds miss disease, even invasive disease in some cases. So you have to be able to say, look, I recognize that you've got classic symptoms of endometriosis here, but I can't find it. So there's a couple of options. We can try you on birth control until you get better. If you don't, we can send you to somebody else who has a little more experience with endometriosis. That doesn't happen very often, but I do hear it's happening more often. I think as the word has gotten out, physicians are beginning to say, well, maybe I don't know enough about this disease. And maybe, I'm familiar with so-and-so who's seeing a lot of endo patients. Maybe he can help us out. And so there's more of that kind of collegial referral saying, I've got a kid here that's really in trouble. I have a good friend in London who has a daughter who at age 12 became disabled. And she was living on the couch. And this kid wants to be a physician, and she's a brilliant student, and she's very committed to her studies. Spent 2 years living on the couch, finally got a surgery. They did a little ablation. It didn't help at all. Also, I think, tried some suppressive medication. It referred her to mental health counseling. So for 2 more years, she's in agony. When she finally gets a decent surgery, she has a nearly obstructed outlet to her bowel. And she's been living with stage 3 or 4 disease now since she was 12 years old. She's now 16. She finally gets relief. We've got to be more sensitive to what people are trying to live with. These are peritoneal signs and symptoms. There's not a medical student or nursing student on the planet that didn't learn the symptoms and the importance of them, unless it seems to be related to their menstrual cycle. Then it's just a period.
Yeah.
And we need to move away from that, because we're seeing patients losing kidneys, and we're seeing patients with ruptured bowels. We're seeing patients with stage 3 and 4 disease having a pregnancy and getting into serious complications, either the patient or the pregnancy or both. We need to do a better job at understanding the impact of the disease on people's lives.
Yeah, absolutely. And like I said before, it's so difficult to maneuver, because you go to your OBGYN and then they're told, everything looks great. We did the ultrasound, we did a lap, and we couldn't see anything. Your uterus looks fine, right? And they miss it because they don't know what it looks like. Endometriosis is all these different colors, and it might not even be on the uterus. It might just be somewhere else in the abdomen, right?
Yeah. Rarely not on the uterus, but most of the time that's what they're looking at. And that's, to me, for 35 years, I've been complaining about things. I'm starting to reframe that around there are opportunities in understanding that we didn't know what it looked like, or we didn't know what the symptoms were. The opportunities for improving people's lives are just a matter of learning some simple things about the disease, like what does it look like? How does it change over time? And where is it found? And, I don't, it is so mind-blowing to me to have patients living in this kind of pain. It's just not right. And yet there's very little understanding of it. And there's not enough understanding of it. Like I said, there are pockets of excellence cropping up everywhere now, but there's not enough of it.
Yeah, and you're told. So I'm going to tell the story of my own daughter. So now she's 28, but well, now she's 31, but she was 28 when she had surgery. But going through medical school, and we're taught, being a naturopath, we're taught, change the diet, you do all these different supplements. And I said, we've already been doing that for 15 years and it's not working, right? I graduated, she sees several of the doctors, in my school. Then I graduate, I ask my colleagues, who are the people that knows what's going on? Who can I refer my daughter to? Who are the top OBGYNs here in Arizona? We go see 2 of them, and it's basically the same. One of those doctors was actually able to say, I think she has endometriosis because it's painful during the physical exam. The other OBGYN, everything is normal. She couldn't even, right? So at least the second doctor could, with palpation, say, I suspect that's what it is. So here we are. So again, but they said, oh, just wait, don't do the surgery yet. Wait until you want to get pregnant and then do the surgery. Well, everything got worse and worse and worse. So then I talked to my sister-in-law. I'm in Arizona. She's in Connecticut. And she says, wait, I have a friend whose daughter had surgery by Dr. Iris Orbach in Los Angeles or in California. And she was talking about this Facebook group. And I started laughing. I said, come on, I just went to medical school. You're telling me to join a Facebook group to learn about endometriosis? And she said, yes, yes, let me find out what it's called. So a day goes by and she says, okay, it's called Nancy's Nook. All the information is there. And literally, we plowed through Nancy's Nook for like
Did
3 or 4 days. Like it was, I mean, it was just nonstop. Whenever there was a break, more Nancy's Nook. And it literally changed and probably saved my daughter's life. So thank you for all that work because it is amazing. And I mean, all I do nowadays is just you have to go to Nancy's Nook. That's where all the information is that's going to change your life. And I mean, it's fascinating to think that a Facebook group knows more than the physician or your teachers in medical school. But it's just, we haven't gotten that far yet. And they're still teaching the old stuff. You do the diet, you do the supplements. If that doesn't work, you do the birth control pill, do the ultrasound. If that's negative, that's probably not it, right? It's probably the cyst. And that's what we've been told for all those years.
And it still goes on. It's still very common.
Mhm.
And you kind of touch on an important piece about once a patient's been seen by a gynecologist who has a good reputation, says there's nothing wrong with it. It's really hard to get another referral or to get
Mhm.
another gynecologist to take you serious. Now, you mentioned the one gynecologist could tell on a pelvic exam.
Mhm.
That's all Redwine used was history and
Mhm.
pelvic exams. And he, whether or not the organs are mobile, whether or not they move, whether or not there's any nodularity. If the exam is painful, he said he always watched the patient's face when he was doing a pelvic exam.
Mhm.
Those were the things that he used as primary because in those days, in the early days of his work, there wasn't a lot of good scanning available. And so there are ways to do a better job of diagnosing, but we aren't teaching.
Mhm.
We aren't teaching it.
Yeah.
We aren't teaching, uh, that the nodularity on the uterosacral ligaments or nodularity or rectal vaginal space or nodularity on the bowel means it's endometriosis. If it's painful, the patient generally will try to get off the table with the speculum still in place. We keep ratcheting open those speculums like we're changing a tire. It is one of the things that drives me nuts. I say, use a smaller speculum and open it carefully.
Yeah.
The minute the speculum blades hit a painful nodule, the patient's just going to go right through the roof.
Mhm.
And so many patients talk about being shamed for crying during a pelvic exam. That's
Mhm.
just unacceptable because back to the peritoneal signs and symptoms, most intense pain that a person can have is inflamed intra-abdominal area. The same thing happens when you touch a nodule during a pelvic exam. They're going to be in agonizing pain, but we just don't have that firmly ingrained in our approach yet.
Yeah, and I know that in Nancy's Nook you have a list of excision surgeons. So they're special surgeons that do a lot of cases of endometriosis excision, meaning that they cut it out instead of just burning the tissue, which is ablation. And can you talk a little bit about the importance of having a surgeon that is an excision surgeon and an experienced surgeon who has done, does this all the time versus a regular OBGYN that's going to do ablation?
Sure. People like the doctor you recommended, Dr. Orbach, Kara King Robinson at Cleveland Clinic, and she did a podcast with me a couple of years ago. We were talking about the importance of physicians who work together. A gynecologist, probably even a good endometriosis surgeon, is not going to be able to handle all disease on the diaphragm, on the small bowel, on the large bowel, on the ureters, sometimes retroperitoneally near the kidney. So having a team of people that you regularly work with is critical. We don't vet surgeons. We don't have the ability to say this person's a good surgeon or not. We get recommendations from patients, and when we get 2 or 3 recommendations from patient about a surgeon, I ask them to give me an email address so I can talk to them. And I will usually tell them they've been recommended to us and why. And I try to prepare them because these are not general endometriosis patients, if they're going to get out of Nancy's Nook, they're going to get people who have been turned away dozens of times. Some have seen 15 different surgeons, and they're still in agony, and they've tried everything. They've lost organs. They've been on every med that's out there. So they're complex cases, and I want surgeons who are going to help us to understand that this is a difficult group. They're exhausted, they're emotionally fragile, they're angry, and they're in pain. And so I like to try to give physicians a chance to look at what our needs are, and do we have common grounds with your skills and our needs. So that's kind of how we get physicians, is that they're recommended. Now, some physicians will recommend physicians that they've operated with and they know their skill level, but we generally don't take just physicians. Somebody will say, well, I know a doctor at so-and-so who I think he's doing some excision. We try to stay away from that because all of our patients have already had multiple treatment failures. So we want people who the physician themselves are confident with their ability to excise endometriosis. Some of the industry is taking exception to the concept of endometriosis specialists or endometriosis excision specialists because they don't think it's an actual category of doctor. But for us, it's a category of doctor that works. These are people who can restore the quality of patients' lives. So we look for doctors who work with teams, who are confident with their ability to handle complex disease, who are willing to look at other pelvic pain generators. One of our concepts is excision is step one. There are so many pain generators in the pelvis that we need to know that if that's not something you're comfortable taking care of beyond excision, then do you have somebody in place you can refer them to for pelvic pain management, or for investigation for hernias, for instance, or for fibroids, or for, pelvic floor disorder. The pelvic floor physical therapy really has come into its own in the last 10 years and are making great strides in helping patients with other causes of pelvic pain. So yeah, it's very important to have people who have skills, who are confident with their ability, who have other consultants they can bring in the event that they run into disease they don't manage. Now, the first time I saw a gynecologist take an endometriosis lesion off the pericardium, the lining of the heart, I held my breath. I said, was there a cardiac surgery team standing by? She said, well, there was one pretty close, but it now is more common in the really advanced skilled surgeons for them to do that. I talked with a fellow, Ricardo Pereira in Brazil, about this concept because Dr. Lee, Ted Lee from UPMC in Pennsylvania, now he's at NYU in New York. But he said, he thought Dr. Pereira had done some of those. So I got a hold of him. I knew him anyway, but I got a hold of him. He said, yeah, he'd done about 100 of them now. And these patients are developing chest pain with exercise, tachycardia. And then when somebody takes an x-ray, they got a little fluid building up around the heart, between the lining of the heart and the heart. And these lesions pretty much are superficial on the lining and can be picked off by a skilled team. So we just see kind of the skills expanding and physicians working together. And I think Dr. King, Kara Robinson King from Cleveland Clinic, was telling me that with their really complex cases, they actually will have a patient care consult before the surgery to talk about all the imaging and all the symptoms and all the tests that they've gathered together. This is going to be a big surgery. It's going to take 5 or 6 hours. Here are the team members that are going to be involved in it. And everybody kind of reviews the information before they start. I think that's an excellent approach in complex disease.
Now, so endometriosis is a whole body disease. It isn't just something that it happens with menstruation. So what is the impact for people that have endometriosis in terms of career, their work, their relationships, just general life?
That's a really major area that is terribly underappreciated. Many of these people spend their lives on the couch with a heating pad, their families, and it particularly rises to the surface over the holidays. When families are expecting them to be there for the big family celebrations or to host one of the big family celebrations and they can't get off the couch. And the families can be very unsupportive in that situation. I hear Donna Locks, who's one of my administrators on Nook, and every year we start around the holidays, we start reminding people that it's okay to set boundaries. It's okay to say no. You can go late and leave early. You can take a dish, not do the whole dinner, things like that. We try to encourage people to set boundaries around that. But it impacts their schooling, it impacts their social lives, and particularly with young people, I'm really concerned about the amount of time they isolate themselves. They're in so much pain. They don't develop their social skills. They're not hanging out with their buddies. They're not able to. Marriages fail regularly. Relationships fail regularly. Partners just finally give up because you're sick all the time. We can't do anything. We can't plan anything. There's no intimacy anymore, that sort of thing. These are all things that really are impactful. One of the things that disturbed me earlier this year was really a very famous surgeon said, well, women aren't having babies because they just won't have sex. They don't have sex because it's not only excruciatingly painful when they have sex, but for many of them, it lasts for a week. I mean, they get all this pelvic floor spasm. They get rectal spasm. They get, just horrible pain. It doesn't go away after one evening of intimacy. And so we don't appreciate that. Parents are not always, although I have to say, I've collected a real cadre of tiger moms who are just not putting up with this stuff when they're being told their kids are going to have to put up with it. No, we don't have to do that. We use a cartoon done by Lily Matthews, and it was published in the Washington Post. They have a newsletter or health letter, I think. Lily did that about 3 years ago, and we use it all the time. It's a beautiful cartoon done taking her anybody through her course over from age 12 to about age 22 before she got relief. And, all the doctors she saw, all the different advice she was given, and none of it worked, And we use that all the time to kind of help families understand this isn't somebody that's just lazy. This is somebody who's feeling a real serious pain, and I cannot live their life. Probably the most gratifying thing that I get and have gotten over the 30 years I've done this has been thank yous for saving lives. I mean, literally saving lives. People who were at their very wits' end. One of the first patients that came to Bend, and she tells this story publicly herself. I won't use her name, but she was a musician from Virginia. And she got a copy of that magazine, Medical Self-Care. We wrote the article that precipitated all the phone calls. She was probably one of the first people on a plane coming to Bend, Oregon. But one of her customers brought in the magazine and dropped it in front of her. I said, I don't talk with women about this very much, but I know you aren't feeling very good. And you might want to look at this magazine. And boy, she was on the phone the next morning. It literally saved her life. She was at the point where she could not concentrate. Her career was at risk. She was just in agonizing pain. In Nook right now, I probably have a dozen patients that I've known for 30 years who do not have pain, who are there to just follow the discussions because they too believe nobody should live like that. The impact on lives is and on potential, for careers or even motherhood or even familyhood, even a marriage or a partnership. It's very, very huge. It's very negative. It's very difficult for them to maintain those relationships. There's the people around them don't really understand. If you don't have that kind of pain, you don't get it. Why are you always on the couch? So we just have so much to learn and so much support that we could bring into making it easier for them while they try to find care. Our whole goal in Nook is to educate them with the basics of endometriosis so they recognize red flags. They can say, whoa, wait a minute, I've been there, done that, like you folks going, the diet, the anti-inflammatory, all this stuff. No, we've been doing that for 15 years. It hasn't worked, we try to teach patients the basics so that they can use those tools when they're sitting across from a physician who says, well, we just take those ovaries out and you're going to be fine. It's time to say, that's not what I want to do. And perhaps to look for another opinion.
Yeah, I think that's really important. And I know that Nook teaches people to be their own advocate. And I know that my own daughter wrote, I don't know, 28 or 30 questions for his second OBGYN we saw. His jaw was on the floor. It's like, and I said, I promise you, I'm not the one who wrote these questions. She wrote these questions. And so, I mean, they were so specific. It sounded like she had a medical degree because she had learned so much in Nancy's Nook that it really floored the OBGYN about the amount of knowledge that she had going into that checkup. So
I think that that's one of the things that started to happen and why we're seeing physicians refer patients to us for education, because for them, it's helpful that patients have that information, that they don't have to spend so much time trying to explain. And like I say, it's not uncommon for us to get patients every week referred by their physician. Interestingly enough, we're having more and more medical students, residents, and a number of GYNs join Nook to observe the discussions, not to provide care. And I don't know what their skill level was. They're coming because they want the information. And they'll say that in their initial things. I'd like to see what patients are saying about endometriosis. So that to me is encouraging. It's a step in the right direction.
yeah, absolutely. Okay, so my last question is, what changes and improvements would you like to see in the care of endometriosis in the next coming years? What's your
I
wish
think the
list?
most important thing we can do for patients, number one, is to listen to them and to believe them. And if we don't have the skill ourselves to take care of them, that we refer them to somebody. I would like to see more of the MIGS programs, minimally invasive gynecological surgery fellowships, teach those basic core things. I mean, they teach how to do minimally invasive surgery, but if you don't teach, finite understanding of the symptoms of endometriosis, what endometriosis looks like, how it evolves over time, where it's found, the statistical distribution of it, and what it takes to remove it all, taking patients to surgery isn't going to work. So you'll always have people saying surgery doesn't work until you learn those basics and use those. When all of those are well applied, we will have far more successful surgery than unsuccessful surgery. That's my belief. I read every history and physical that came to Bend, and some 3,000 patients. I read every history and physical that they brought with them, and every history and physical and operative report that was done while they were in Bend the whole time I was there. And you could just see the difference in the understanding and then in the progress of the patient, how well they did. Having had multiple surgeries prior to coming, and the minute you get them in surgery, you look at their previous films and you can see diseases there. You remove that disease, then their lives get better. There is a small degree of recurrence. I mean, you can't deny that some people don't have all their disease developed at the time they go to surgery, but if they're in agony, you should get that disease out so they feel better.
Well, it's been a pure pleasure and joy to have you as a guest today, Nancy, and just sharing all your information. So we're also going to put the link to Nancy's Nook in the podcast notes. So for all you listeners out there that are either struggling with unresolved pain or weird symptoms, like even leg pain, right? Like Nancy had, go check out Nancy's Nook, or like my sister-in-law who gave me the information. Give out that information, because there's so many people that struggle with painful periods just in general. So, give that information out so that they can get the care that they need. So again, thank you so much, Nancy, for taking the time and being a guest today.
Well, thank you for having me. I always enjoy trying to spread more information. I appreciate that much.
As we conclude this episode, I want to express my heartfelt gratitude for your presence within our community. If you haven't yet, make sure to subscribe, leave a review, and share this podcast with friends and family. Subscribe to my newsletter in the show notes and receive new podcast episodes delivered right to your inbox. If you resonate with the interconnectedness of mind, body, and soul, and are motivated to embark on a journey of personal healing, I invite you to connect with me at drlottie.com. Together, we can pave a path towards transformative healing in your own life.